Good afternoon, everyone. My name is Andy, and I work at the Center for School Mental Health, and I'm hosting today's webinar, so welcome. Thanks for joining us. Today's webinar is the second webinar in a three-part series on the Mental Health First Aid First Nations. The first webinar in this series was Program Development and Vision by Anne Seymour, who is the Indigenous Program Specialist at the Mental Health Commission of Canada. And that webinar is now posted on our website for you to view if you missed it or if you want to share it with your colleagues or anyone who's interested. And Nicole is going to share our website in the chat bar. If you can't see the chat bar, just click on the purple arrows on the bottom right corner, and that'll open up a panel where you can click on the speech bubble and you'll see, thanks Nicole, where you see a spot where you can chat. If you have any technical questions or problems, you can just send a private chat to Nicole Bullock and she can help you out. I'd like to invite you all at this time to send a message to the entire group just to introduce yourself and say where you're from. It's really nice to see where everyone is tuning in for from all over Canada. If you have any questions that you think of as we're going along the presentation, feel free to type in the chat your questions and we will address them at the end of the presentation. So I think that's it for the housekeeping. So thanks everyone for tuning in. It's my pleasure to introduce our speaker, Dr. Claire Crooks. Claire is the director of the Center for School Mental Health at the Faculty of Education, Western University. Claire is a registered psychologist in the areas of clinical, school, and forensic psychology. In her research, Claire looks at how effective programs get adapted and implemented in different schools, communities, and diverse populations. For example, Claire co-created Healthy Relationships curriculum and programming, which have been adapted for different contexts, including First Nations, Métis, and Inuit youth. Claire is the principal investigator for the CAHR grant to evaluate the feasibility, implementation, and impact of the Mental Health First Aid for First Nations program by the Mental Health Commission of Canada and several First Nations communities. Claire lives in London, Ontario with her husband, her 4 young children, and her brand new puppy. Welcome, Claire.
Thanks, Andy. Can you hear me?
Yeah, you're good.
Yes, okay, good. All right, welcome everybody. Welcome back if this is your second time, and welcome if you're just joining us for the first time. Thank you for your interest. So today I am going to talk about Mental Health First Aid First Nations and some of our research findings and outcomes. And this is, as Andy said, the second part of our series, and next week Andy will be talking about what we learned about cultural safety in both programming and research and the importance of it and indicators of it. So I'd like to start by recognizing that this work was done by a larger team. This picture here is a team of most of us, a number of women who work with the all Indigenous consulting firm called Reciprocal Consulting out West. Myself and Andy are here. Angela Snowshoe was also involved with this project. She's a professor at the University of Regina and is missing from this photo. I'd like to thank the Canadian Institutes of Health Research for the funding and acknowledge the First Nations communities around the country that played such an important role in sharing their experiences and voices, and also the Mental Health Commission for their partnership. So I'm going to give a 2-second overview of mental health first aid and Mental Health First Aid First Nations for people who weren't here last week. As a reminder, the whole webinar is available on our website. So if you missed it, I would encourage you to go back and listen to Anne's description of how it was developed so thoughtfully and to be really different than Mental Health First Aid Basic. So in a snapshot, mental health first aid is the help provided to a person developing a mental health problem or in a mental health crisis. So it's that analogy that if somebody sprained their ankle, you would know what to do, you'd recognize the signs, you'd know how to keep them comfortable, how to keep the injury from getting worse, how to get them the help they need. And yet we don't have that language or skill set or comfort when it's a mental health issue. So again, it's not turning people into paramedics or social workers. It's providing the support until appropriate professional treatment is received or until the crisis is resolved. And Mental Health First Aid First Nations has a number of things that make it different from the regular or mental health first aid basic course. But the main features are this acronym EAGLE. So these are the first aider skills: engage and evaluate the risk of suicide or harm, assist the person to seek professional help, give reassurance and information, listen without judgment, and encourage self-help strategies, gather community supports. The other things that Anne talked about last week, again, are that notion of walking in two worlds, or navigating First Nations worldview and community and relationships, and also Western approaches to mental health and well-being. She talked about the inclusion of elders and using sharing circles in the delivery of the course, and this notion of circles of support, or the whole group coming together to map out what resources, formal and informal supports, are available in a particular community to help break down some of the barriers that exist even between service providers and community. So again, that's a very quick overview because Anne did such a nice job talking about that last week. So back in 2012, I was actually contracted to do a pilot evaluation by the Mental Health Commission of Canada. And at that point, the program was very much under development. And so the program was still changing, and we were trying to evaluate it at the same time. And it was a bit of a runaway train. And what came out of that was just that there's a real need for this program, a lot of interest, and it needs to be done carefully. And now here we are, 5 years later, and the program has been developed and stabilized, even though, as Anne talked last week, it's an ongoing living document, and we have done our first evaluation. So in thinking about what questions we wanted answered, we actually spent quite a bit of time with the first 3 pilot sites trying to just identify sort of or co-create areas of inquiry. So not even really specific research question, but what were the areas we wanted to learn about? And we came up with these 3 overlapping ideas. And one is implementation. So how is this program being used, and who's getting it, and what are some of the barriers and successes for facilitators or organizations to actually implement it? Cultural safety, which again is next week's topic. And then impact, which is it doing what we want it to do in terms of gains for participants? And that's the area I'm going to talk about today. So the kinds of things that we wanted to look at, some of these impacts are well documented in other mental health first aid evaluations. So you hope that people are learning knowledge. You hope that stigma attitudes are reducing. Hope there's an increase in self-efficacy, which is that feeling that you can competently use particular skills that when you need to, and we also wanted to look at the application of skills. I think what's different with this is we also, in thinking about knowledge, we wanted to go beyond just looking at how people learn the signs and symptoms of mental health crises. Have they learned just the EAGLE steps, but also, because Mental Health First Aid First Nations really grounds mental health and mental well-being within that larger framework of lived experience and colonization and residential schools, was there an increase there in terms of knowledge about what we are calling social determinants of health, and how the legacy and the history of the relationship between Indigenous and non-Indigenous peoples in Canada has played such a significant and negative role for many communities and individuals. The other thing, this last step, application, we did also really want to go beyond just, do people feel like they learned the information, can they apply it in a scenario initially, and then down the road, are they actually using it in their real lives? So again, our evaluation approach, I'm going to touch on briefly because I want to get to our findings. I will remind people we already have a summary posted of our whole project on our website, and our full technical report will be going up in the next 10 to 14 days. So anyone, if there's some research nerds in the crowd, there's certainly a lot more detail available. But just kind of the general principles, wanted it to be co-created with communities in terms of right from the research questions to the methods to how the data were used. We were taking a mixed methods approach, which means we talking to different people and looking at different ways of sharing experience, and then looking for convergence and areas of divergence across those methods and groups. So we really want to give people choice about when and how to add their voice to the evaluation. We wanted to privilege voices over numbers, so we were doing some quantitative things in terms of surveys that we can use statistics with, but also really wanting to get behind those to the stories and experiences. We spent a lot of time thinking about, okay, so is this Indigenous methodology? What is it? And we decided, it's not truly Indigenous methodology because we had these pre-established areas that we wanted to know about: knowledge and attitudes and self-efficacy. And in a true Indigenous methodology approach, we would have just created space for partners to decide specifically what story they wanted to tell. So we think we still really worked hard to make sure that that there was benefits to the community, that we were very relationship focused, and we had lots of other pieces that I'll talk about that lead to what we are calling an Indigenous community-based partnership framework. And then also we really wanted to assess whether participants felt it mattered in their everyday lives and roles. And for us, that meant sort of a check-in or follow-up 3 to 6 months later. So it wasn't just, did you learn this now, but okay, now that the dust has settled, have you used it? Is it helpful in everyday life? That sort of thing. So again, we ended up with about 90 interviews and online surveys from 10 different groups that were run across the country. And there's only about a 40% overlap there, where about 40% of the interview participants also did a survey and vice versa. But again, the idea was that we wanted people to have some choice around how to share their experience. We did a follow-up survey and had a smaller group that completed those. We did interviews with course facilitators and implementation surveys with course facilitators as well. And the heart of this was we had these research teams, these FIRE teams, 2 researchers who would go out and spend 3 days as part of the course and fully participate in the course and build those relationships and let people share their stories sort of how and when they wanted to, and make observations and take course notes as well. So that was our sort of data collection matrix. We did try to keep the OCAP principles forefront of mind. So we immediately shared interview transcripts and gave participants the option of changing or holding on to their words or deciding if they wanted anything different. We provided plain language summaries back to the community to tell the story, these very attractive 2-page summaries within a couple weeks of being there. So again, that very kind of rapid response of people seeing where their words and data went to, instead of what sometimes has happened with academic research, where people share their stories and their experiences and then 18 months later there's publication or something. And we spent a lot of time really empowering participants to understand the purpose of the research, their autonomy of choosing whether or not they wanted to be involved, how their knowledge and story would contribute to the research. And we actually had some interesting feedback about how that was quite a positive experience, which is particularly important given the legacy of negative research experience for many First Nations communities. So one of the things, our survey, we spent a lot of time thinking what to put on our survey, and we used something called a retrospective pre-post for part of it, which means that people only did the survey at the end of the course, and they were asked to rate their knowledge in a particular area before and after, but you're doing that at one point at time, which is different than true pre-post, where you do sort of a pre-survey and a post. And I just want to use this as an example to talk about some of the considerations that we had about trying to do methodologically and ethically sound research. So there's advantages and disadvantages of this retrospective pre-post methodologically. So one advantage is that you're now doing one administration, so they just have to do the survey once instead of twice. And retrospective pre-post has been argued to be good when you're asking people to comment on something where the frame of reference might change. So when you're asking someone, how good are you at doing something, and then they learn a whole lot about it, like their whole frame might shift in terms of where they saw their competence. And so somebody might rate themselves lower after because they realize how complicated the skill is, for example. Whereas if you're doing a retrospective pre-post, knowing what they know, they can kind of think back to where they were and to think where they are now. Another disadvantage of a true pre-post is it can be really hard to come up with knowledge questions, for example, where you're not just turning it into a literacy or a reading comprehension test. So you start using sort of double negatives and things to try to get some variability in the answers, and then it's not really clear what you're measuring. The disadvantages, of course, are that they're not of a pre-post, retrospective pre-post, is it's not considered as accurate as a true sort of test at the beginning and after. And what previous research had, when they compare the two approaches, so there was medical education where people were asked to do a retrospective pre-post, and they did a true pre-post test. And what they found was that a retrospective pre-post, people are very good at saying, yes, I've learned something in this particular area. Like, they were good at identifying where they had made knowledge gains. They weren't as accurate on the magnitude of those knowledge gains. So that's sort of the trade-off. Beyond methodology, there were some significant ethical considerations in that it's very intimidating to start this kind of course with a test, or what feels like a test. So people are coming to do this program. They may or may not at that point know that there's an evaluation component. If they arrive that first day, maybe they're feeling anxious about the course in general, and they're greeted by a researcher saying, hey, do you want to be part of this? Here's informed consent. Here's a test. That can be a very anxiety-provoking experience and disruptive. And also recognizing that many First Nations adults have not had good experiences with school for a whole wide range of reasons that many of us are familiar with, but not wanting to start the course by sort of bringing those feelings back, bringing back negative memories and feelings of being in school and feeling like you don't know the right answers. And so what we felt was that the retrospective pre-post methodology is more respectful, and that we're basically saying, we trust that adults, we respect that autonomous adults have the ability to reflect on an experience and say, yes, I gained from this, and that's how it went that way. The other thing I want to mention is this balancing culturally relevant approaches with logistics and community preferences. And we had a couple of really sort of interesting experiences where we thought we were being really culturally relevant. And bear in mind, we have a research team with 8 researchers, and I'm the only non-Indigenous member of the team. And so the other 7 have lots of experience with Indigenous methodologies, and I also have some. And so one thing we wanted to do early on, we wrote a whole protocol for using photo voice, because there's a lot of good arguments for photo voice as being particularly culturally relevant and empowering. And then when we went to our communities and our advisory, we actually, the feedback we got was that it's just too much. It's too much of a burden to place on people going through this very emotionally demanding course. And we appreciate that you're trying to be sensitive with your methods, but really we would actually just prefer a survey at the end and interviews. So that was sort of interesting that we thought we were being really culturally relevant and it didn't meet the needs of the community. Similarly, our follow-up was intended to be a community-based sharing circle and feast where we would go back, and the whoever had hosted the initial training would bring people together, and we would have a very open discussion about how people were using the program and some of the successes or barriers. And we set up the first one and went, and they had quite a few people sign up, and then people's lives are busy, things come up, everyone has a lot of other competing demands, and we had one person show up. So now we're trying to balance out, we loved this idea of going back and having sort of a feast and bringing people together, and lots of people wanted to be part of it, and then the logistics and the busyness of everyday life was such that it wasn't cost effective, and we weren't going to get the most sort of voices that we could. So that's where we were recommended to go to a follow-up survey. So I think what we learned is it's great to be open to lots of methodologies and to be aware of the different pros and cons, but the community-based partnership approach means that you're really negotiating that with and navigating that with your partners and figuring out what makes sense. Okay, so in terms of survey participants, you'll see here we had a range of ages and mostly female, which reflects the participants in the courses as well. The average age of participants was 42. About 80% identified as Indigenous, and of the different groups that we were involved with, 7 of the 10 had entirely Indigenous participant makeup. Some of them were community organizations where they might have been doing training for frontline providers at a friendship center. Sometimes it was a pre-existing group, like all the nurses or all the health directors of a region, or chief and council in one case. Other times it was more open registration. So very, very diverse groups in terms of their previous training and professional roles, and how they were coming to this work. So when we look at mental health literacy, which is this multifaceted domain that looks at to increase mental health literacy, you need knowledge, you need to have the skills and feel like you can use them when the time comes. And we wanted to look at whether there was pre-existing differences in terms of the groups based on the training they had. So when we looked at sort of people who had no formal training, some kind of community-based training or certification, and then some post-secondary training, and we looked at our different indicators, what we saw was that, not surprisingly, there was numerous differences. So on this chart, on this table, if the colors are the same, then it's not a significant difference. So if you look at knowledge and mental health, then people who have post-secondary training or other certification are not significantly different from each other, whereas people with no formal training rated their mental health knowledge as lower. The second one, the SDOH, is again social determinants of health. So understanding how the impact of colonization and social support and these other factors play a role in well-being. And here all 3 groups were different. So you see there's these pre-existing differences. And one of the reasons we split people out like that to look at the data were that we really wanted to know, does this program offer something to everybody, or is it better for people who have no training or who have some training, and so that's why we did that. So I'm going to show you the numbers. Again, this is just really converged with all our interview data, which is the more interesting data, but this is what the tables look like. This is one example. So looking at their knowledge of mental health, you can see these lines pre to post, all 3 lines go up, and those are all significant increases. So regardless if people came into this with no training, with some community training, like maybe ASSIST or mental health first aid basic, or whether they had gone to school to be a social worker or nurse, everybody felt that they increased. And we really heard this as well in the interviews. So very specific signs and symptoms. For example, this is one male participant said, "I really learned about risk signs and factors I wasn't aware of in terms of suicide ideation, e.g. giving away of things. Before, I never thought it was a sign. I would have accepted it as a gift. Thank you for thinking of me. That surprised me in terms of what I learned so far." So those really important kind of knowledge pieces about signs and symptoms, but just as equally important were the things around social determinants of health, for example. And I didn't include all the graphs because the mental health literacy, the knowledge, the social determinants of health knowledge, and the self-efficacy all look the same, where there's a change in how people start and they all improve. But looking at things like social determinants of health, these are the kinds of things that people said in interview. There's a lot of people that don't know our traditions. From a perspective of not living in community, this would be effective as a teaching component for non-Indigenous people, and how that historical experiences that we have had can impact our trauma and the mental health issues that we experience. So people seeing that this is not just for Indigenous service providers and community members, but because there's this social determinants of health or historical context, that's something really important for everybody in Canada to know about. In terms of specific things like the circles of support exercise that Anne talked about, where they map out all the community pieces, those sorts of things. Again, so what the program was doing really showed up in the interview. So one of the participants said, "Seeing it up on the wall like that, there's so much help out there for people. We just need the guidance to find that support. This course will help us share that this knowledge is out there." So again, the importance of knowing what's available in a community. And I think what was interesting for us is that lots of mental health first aid basic evaluations show an increase in knowledge and decrease in stigma beliefs, for example. But there was a different quality to some of what people were experiencing or gaining. That it was beyond just learning facts or steps even, but these really kind of personal reflection or transformation experiences that wouldn't necessarily happen in mental health first aid basic. So here's something the way a facilitator describes it. Throughout the course, the participants began to share very personal and powerful experience. One participant was able to talk openly about a family tragedy for the first time and thanked us for allowing him the opportunity to gain some understanding of the tragic events. Many participants indicated that they grew in knowledge and in spirit throughout the course. So that's something that's a little harder to measure, but really it's not intended to be a therapeutic intervention, yet for many people, this knowledge and context and hearing about mental health in this way was had a very big impact beyond just sort of knowledge and skills. In terms of stigma, we saw a decrease in stigma, but interestingly, the bottom line, the no training line, was not a significant decrease, and the others were. So what that says is that people who have previous training reported lower stigma beliefs, a decrease, and people who, the blue is the no training, because it's the opposite here, where higher scores are not good because it's stigma beliefs, and the blue is not a significant decline. And so it may just be that if this is the first time you're learning about stigma and the role that it plays in well-being, that maybe 3 days isn't enough, and that this is the start of a conversation, but something that takes more time. So another part of our evaluation, we looked at application of skills to a scenario. So the participants were given this scenario in their survey about a hypothetical friend who's described as suffering from a possible mental health crisis. And we didn't say to them, what Eagle skills would you use, or just these very open-ended, what would you do? Do you think this person needs help? What would you do? Tell us the words you would use. Like, what would you actually say to this person? And then we coded their responses to look at whether or not they were using Eagle strategies, regardless of whether they called them that. And the thing about Eagle strategies, they don't have to be in a particular order. It's not like CPR where there's this specific protocol. These are all strategies you can use. So all of the respondents identified they were concerned about John and that he might be dealing with an issue that required assistance. And that's an important finding, that part of what this course does is get people to just think a little differently about sort of their personal responsibility or agency in helping when somebody is having a mental health challenge. In general, the mean was about 2.6 or 3 Eagle strategies in the responses when we coded them, and the most popular Eagle strategy, or the most commonly used, was engage and evaluate the risk of suicide or harm, which is obviously a great starting point for any future work. So that's all very promising in terms of our initial evaluation, but we really wanted to look at sort of, does this matter down the road? And that's where we did do this follow-up survey about 6 months after people had done the group, and it's only 27 or 28 people, and we just were asking things like, did you learn anything in this course that you use in your daily life? Have you had the opportunity to use your first aider skills? Did you use them? Why or why not? What gets in the way? What happened? And so again, this is a very small group, but really very promising in terms of the practical application to people's lives. So 85% of the survey respondents said that they learned things in the course that they use in everyday life. 63% identified they had a situation where they could have applied their skills. And I think that's where, we often talk about this analogy with physical first aid, but I think where mental health first aid has even potential for bigger impact and community change is how often we all can use these skills. So, I've been trained in CPR for 27 years. I've never actually had to pull it out. But when you know how to respond to somebody who's experiencing severe anxiety or thinking about self-harm, you are going to have those opportunities to use those skills, because just the prevalence and how common those experiences are. 94% of respondents who had the opportunity to use their skills did. And it's very compelling, the sort of stories they told. And I'm going to give you two examples because I think the words just really speak for themselves. I've had someone close to me come to me with suicidal thoughts and urges. With my knowledge from the training about dealing with mental health emergencies, I was able to listen and direct this person to the resources I knew available in our community. The person is currently receiving help at the professional level. So that's hard to quantify. That's somebody talking about an intervention that potentially saved someone's life. And you can see in their answer that all those parts that we wanted to see, so the knowledge, so they recognize that this is a situation that requires intervention. They clearly identify that it was their training that helped them know what to do, to listen, and which is part of EAGLE, and to direct the person to resources, and the outcome being that the person is now professionally supported. So very, very compelling about the potential for this kind of intervention. Here's another one. I knew how to respond to someone contemplating suicide, and I knew how to use my body language with our First Nations people. It's different than the regular population, as well as the eye contact. I hope my actions help the individual. This person is still here with us today. As well, they confide in me completely. Thankful for Mental Health First Aid First Nations. So very compelling within this small group who opted to do the follow-up surveys, but very compelling examples where people really felt like they had the skills and the framework when they needed them. So another question we had then is this an effective community level intervention for stigma? And we ask people, has stigma in your community or in your organization changed since Mental Health First Aid First Nations? And the answer that came out in this small sample is it's really an issue of saturation, or I think getting to that tipping point where enough people have had the same training and are speaking the same language. So here's an example where it was more contained within the organization. Within my company, yes. Within the community, it's more difficult as they have not received training. So change in stigma, how people talk about mental health, how people see it amongst a group who within one company had all been trained, but didn't see that trickling over. On the other hand, this is a very low-cost, scalable intervention, and so when you start to see that tipping point, you may see a different ripple effect, and this is another participant's experience. So their community is quite a small community compared to others, and when this training was provided to many people, I feel it created a ripple effect on breaking stigma and negative attitudes. People were going to their own families and telling them what they learned, and starting many conversations about mental health. So again, giving people the language, accurate information, and a framework for having these conversations that we have not always had. So overall, I think what we would say then is that Mental Health First Aid First Nations shows promise as an effective and feasible public health approach to promoting well-being across a range of First Nations contexts. This is very preliminary findings in that there's still a lot of work to be done, I think, in terms of evaluating this course. Next steps could include a larger sample size, more community-based participants, and what we mean there is a lot of groups were for pre-existing either Friendship Center staff or other pre-existing groups. So how this rolls out when you just put up a poster at the local high school and open it up to anybody walking in the door, I think needs to be evaluated. And at some point you want to compare it to other models or not being involved in training. And it's tricky here because from a sort of Indigenous methodologies point of view, you don't emphasize things like control groups. On the other hand, we've seen other evaluations where evidence-based practice that got dropped into a First Nations context was actually worse than doing nothing. It made people kind of more distressed and didn't increase their self-efficacy at all. So having some conversations around how to responsibly and ethically look at that question, how would we know with our design that we're not making things worse, would be another important first next step. So just to close, I wanted to just leave you with two more quotes. again, the stories that people were so generous in sharing their experiences, and I come back to the point that, sure, we saw increases in knowledge and increase in stigma and all those things that we wanted, or that you would hope to see based on other mental health first aid evaluations, but the importance and the possibilities had a really different feel to it in many cases. So in terms of the importance, here's somebody's words. I like the program. It's something I needed a long time ago. I wish it could have been brought to my attention a long time ago before my brother died. It should be offered to the public, not just service providers. So somebody, looking at their own history and sort of saying this might have been this might have changed the outcome if I'd had those skills back then to know what to do. And then here's another one. Because I don't have any counseling background, I never thought I was capable at helping people. I knew I could, but I didn't feel confident. But with this, I think I would be able to help more in my job. I mostly work with youth programming. So again, recognizing, we're never going to have enough social workers and psychiatrists and psychologists to try to sort of just treat mental health challenges in communities, and a lot of those services aren't culturally relevant or sensitive. And so how do we build this groundswell of mental health literacy where everybody who works with youth, with other people, everyone who has neighbors and family members can use some of these basic skills in the face of an emergency or crisis? So just to wrap up, mental health appears to be a success at this point. I think there's a lot to be still evaluated. Next week, when Andy talks about cultural safety, I think that really will highlight one of the strengths of the course that we didn't get into today. And there is more information on our website. We have a couple of papers submitted and a few more being finished off, but anyone who works in this area knows that takes like another year and a half for them to show up. So we've done a plain language summary that's available now. Our technical report will be coming out soon, and we have a brief summary of facilitator experiences as well. So thank you so much for your time, and I welcome any questions. Andy, back to you.
Okay, thanks, Claire. Thanks for that excellent overview of the outcomes of mental health first aid First Nations, and sharing a snapshot of some of those really amazing quotes from the participants that we heard throughout this evaluation. So feel free, everyone, to type in your questions in the chat bar. So far we have one question from Anna, and I think, Anna, correct me if I'm wrong, but I think this was specifically a question about the stigma and the graph that you were showing.
Yeah. Around the quantitative pieces, we compute effect sizes. So the short answer is I haven't, Anna. We have a really small sample, and we developed our own questions. The stigma one was interesting. There's lots of well-established stigma scales, and when we looked at them, we felt like a lot of them had very much sort of a middle-class Western bias. And I'll give you an example. It'll have questions saying, people with mental health could get a good job if they wanted one. They just need to try harder, which is a stigma belief. But in the context of many First Nations communities where there may be very limited employment opportunities, that may not be a reasonable. Like we just felt like they weren't very the scales weren't very specific. So to compute an effect size, as you know, you sort of would want to know kind of what sort of change you're looking for, and you'd want to have more you'd want to have more confidence that you had a really solid measure, quantitative measure. In this case, we were doing a mixed methods approach, and we were looking for that convergence, but we really, from an Indigenous community partnership point of view, we're wanting to emphasize more the interview answers as well.
Thanks, Claire. Okay, so I think that's all for now, but if you have any questions, you can feel free to contact Claire at her email that's on the screen, or please do check out our website, which is also listed. And don't forget to tune in next week for the cultural safety webinar, which is going to be we're going to talk about cultural safety in the program as well as the research and evaluation. And as always, if you can't make it, it will be posted on our website as well. So you can feel free to check it out there and share it whenever you like. So thank you everyone for joining us today. Hopefully we'll see you again next week. Bye for now.